Myself, Dr. JIBRAN Ahmed presents to you Simply Pathology, and today we are back with a very important session. This topic, that is the malabsorption syndrome, is a very important topic. Okay, so in the recent years, what we have seen that an increasing number of questions is now being asked from the malabsorption syndrome. Okay, and it is basically asked as a long answer question in your exam, can be asked for 10 marks or 20 marks. Okay, now why it is very important for you to go through this lecture, because this is not given nicely anywhere. Okay, and very importantly, there are number of entities under the umbrella of malabsorption syndrome, so it is not possible for you to individually discuss the entities in the exam, because in the exam for a 10 or 20 mark question you can spend at the most 15 to 20 minutes. You cannot spend more than that. So you need to have a very concise note which is describing each entities very briefly. Okay, not only that, I have also discussed in details about the laboratory diagnosis so as to how you can streamline the diagnosis. So that is why this lecture becomes very important from the exam point of view. Okay, so let us begin today's topic of discussion without wasting any time. So what is malabsorption? If you look at the definition, malabsorption is characterized by defective absorption of fat, protein, carbohydrate, or fat and water soluble vitamins, minerals, electrolytes, and water. So malabsorption results from disturbance in at least one of the four phases of nutrient absorption. So what are these four phases? So we are having intraluminal digestion, which is characterized by protein, carbohydrate, fat breakdown into simpler forms so as to facilitate absorption. Then comes the terminal digestion phase, characterized by hydrolysis of carbohydrate and peptides by disaccharidases and peptidases at the brush border of the small intestinal mucosa. Thirdly, you have the transepithelial transport. Okay, so after they have been broken down at the brush border epithelium, now the nutrient has to be absorbed across the small intestinal epithelium. So all the nutrients are processed and transported across the small intestinal epithelium. This is the phase of transepithelial transport. And lastly, okay, in some cases, in some nutrients, lymphatic transport becomes important. For example, for absorption of lipids. So for absorbed lipids, they has to be further broken down, emulsified, and they have to be absorbed, okay, in the form of chylomicrons, micelles. Okay, so this also requires lymphatic transport. So fat is basically transported in the lymphatics. Okay, so lymphatic transport is important for transport of absorbed lipids. So these are the four important phases of nutrient absorption. So usually there is a defect in one of these process, okay, primarily. So if you see any malabsorption condition, okay, so all four condition or all four status, okay, all four factors may contribute, but one of them is predominant. Either one of them becomes predominant. So one of the phases becomes predominant. Okay, so usually a defect in one of these processes predominates in any malabsorptive disorder, but several usually contribute. Okay, so I'm repeating again. So in a particular malabsorptive condition, okay, usually predominantly one of these phases are affected, but usually if you see all these phases are affected, and usually most of them with one of these phases more prominently affected. Okay, now for simplicity and easy of understanding, okay, examples of malabsorption will be discussed according to the nutrient which is affected, like fat malabsorption, carbohydrate malabsorption, protein malabsorption, like that we are going to understand. Okay, so basically what I want to say that, for example, celiac disease. So celiac disease is the condition where there's a diffuse affection of the entire small intestine is affected diffusely. So it is not only it is not only affecting fat, but it is also it is also affecting carbohydrate and protein absorption as well. So that is the basic reason that, for example, it doesn't mean that a condition discussed under fat malabsorption or protein or carbohydrate malabsorption is limited to that nutrient malabsorption only, but rather it is limited or predominantly limited to that particular this thing. Okay, so I will discuss about that. So what are the major disorders to be discussed in brief under the malabsorption syndrome? So we will discuss about the cystic fibrosis, celiac disease, A beta lipoproteinemia, SIBO syndrome, Whipple's disease, tropical sprue, autoimmune enteropathy, intestinal lymphangiectasia, and disaccharides deficiency. Okay, so all these important malabsorption conditions will be discussed in brief over here, because we have to complete this topic as a whole, as an exam topic, as a long answer question in the exam. Okay, so we will discuss in brief about these and most important points and the differential point which will help in the diagnosis of these conditions. Okay, so for the simplicity, we will basically start off with the etiopathogenesis. So first we will see the fat malabsorption. Okay, so fat malabsorption is one of the most common malabsorption syndrome. Fat digestion begins in the mouth with mastication and with the help of lingual lipase, and majority of fat absorption occurs in the proximal small intestine with the help of your stomach and pancreatic enzymes. Okay, like pancreatic lipase is there. And once the fat is broken down, further fat emulsification and solubilization requires two things. So it requires a increased pH, that is the basic pH is required, and they require bile salts. Okay, they require bile salts which are basically synthesized inside the liver and then stored in the bile. So via the pancreatic duct, the bile salts are entering the duodenum. Okay, so with so at a basic pH and with the help of bile salts, they form micelles, and this will be further processed to form chylomicrons, and then they will be absorbed into the lymphatic circulation. So lymphatic absorption or lymphatic this thing is important for fat absorption. Okay, so this is what happens normally for the fat, and any of this process, if it is haywire or if there is any defect in any of this process, so there will be fat malabsorption. So let us now consider what are the causes of fat malabsorption. So number one, a reduction in the duodenal pH. So as I told you, a basic pH is required for fat emulsification and solubilization. So if for any reason there is a reduced duodenal pH, so the optimal pH which is required is 6.5. So one such condition is your Zollinger-Ellison syndrome. This is a gastrin secreting neuroendocrine tumor characterized by increased gastric acid production secondary to the gastrin production. Okay, so this leads to peptic ulcer formation and chronic diarrhea including steatorrhea. And there is malabsorption. Malabsorption is occurring due to the inactivation of the pancreatic enzyme because of the increased acidity. Okay, and increased excess acidity of the stomach content which is entering the duodenum. There is inactivation of the pancreatic enzyme, so further fat breakdown is not there. Secondly, there is a direct mucosal damage by the acid. And thirdly, the bile salts in the acidic medium, they are precipitating, so they are not able to help in the fat processing. So all these three factors are because of excessive gastric acid production in the Zollinger-Ellison syndrome. So in condition of Zollinger-Ellison syndrome, you will see chronic diarrhea including steatorrhea. Especially steatorrhea, that is fat malabsorption, is very predominant in this condition. The second condition is when there is a loss of the absorptive intestinal surface area, when the surface area is lost because of any disease. So the disease can be a diffuse mucosal or enterocyte disease, like for example Crohn's disease and ulcerative colitis. Now this is an inflammatory bowel disease. Now over here we have discussed IBD over here, but IBD also plays a role in protein as well as it will play a role in carbohydrate malabsorption as well. So in short, we have already discussed in details about the IBD in details in the IBD section. So over here, very briefly, we will understand what IBD is. It is a condition characterized by inappropriate mucosal immune activation due to complex interaction between intestinal microbiota and host immunity in genetically predisposed individual. This is what inflammatory bowel disease is. Okay. Now, the second important condition that we will see, that there is a diffuse mucosal or enterocyte disease, that is a celiac disease. Now, again, celiac disease is not only limited to fat malabsorption. It will also lead to carbohydrate as well as it will lead to protein malabsorption as well. So in brief, we will try to understand about the celiac disease. It is an immune mediated disorder which is triggered by gluten containing food in genetically predisposed individuals. Okay, so especially which gluten? Gliadin. So basically among the gluten, gliadin is mainly responsible. It induces stimulation of both innate and adaptive immune system, okay, which causes tissue damage, that is they damage the intestinal epithelial cells. So if you look under the microscope, if you look at the microscopic picture, you will see excessive amount of intraepithelial lymphocytes. You will see villous atrophy, accompanied by crypt hyperplasia as well as crypt elongation. And because of increased turnover, because of excessive damage and increased turnover of the intestinal epithelial cells, you will see an increased amount of crypt mitotic activity as well. So this is in short about the celiac disease. Okay, this is in short about the celiac disease and the IBD. So this is the diffuse mucosal enterocyte disease. Then, thirdly, this was the loss of absorptive intestinal surface area. Then thirdly, you can have a pancreatic exocrine deficiency. So as you have seen, pancreas is releasing a lot of enzymes like pancreatic amylase, pancreatic lipase. Okay, so these enzymes are responsible for, pancreatic lipase is there, amylase is there. So these enzymes are very important for digestion of fat, carbohydrate, okay, as well as even protein digestion, it is important, okay. For example, release of trypsin, chymotrypsin, responsible for protein digestion, also comes from the, pancreas. So pancreatic exocrine deficiency, again, it is not only going to cause fat malabsorption, but it will also lead to carbohydrate as well as protein malabsorption. So it is also discussed over there. So pancreatic exocrine deficiency leads to defective production of pancreatic enzymes, as I told you, like the lipase, amylase, all the trypsin, chymotrypsin, as well as the production of bicarbonate, which is helping to achieve the alkaline pH. So when can you see the pancreatic exocrine deficiency? You can see in conditions of chronic pancreatitis secondary to alcohol abuse or chronic biliary obstruction, or there can be thousand other conditions, reasons for chronic pancreatitis. Secondary to pancreatic carcinoma, there is an obstruction and there is loss of function because of damage to the pancreatic tissue. So pancreatic carcinoma leading to obstruction and loss of functional pancreatic tissue. Then pancreatic resection. So there's a reduced production of pancreatic enzymes because of pancreatic resection. Then we are having cystic fibrosis. Now cystic fibrosis condition, if you see, remember, it is primarily affecting the lungs, and we have already read about cystic fibrosis in details. But over here we are going to concentrate on that part which is associated with malabsorption. Okay. So cystic fibrosis primarily affects the lungs, okay, and the patient will have history of recurrent respiratory tract infection. It occurs because of the mutation leading to absence of the CFTR channel. And as a result, this leads to defective chloride and bicarbonate ion transport. So there is an interference with the bicarbonate sodium and water secretion, leading to reduced hydration of the luminal contents, leading to formation of pancreatic intraductal concretions, which is causing pancreatic duct obstruction, leading to chronic pancreatitis with auto digestion of the pancreas, ultimately causing an exocrine pancreatic insufficiency, and secondarily there will be malabsorptions. Okay, so this is what is the problem in cystic fibrosis, and this is how they are causing exocrine pancreatic insufficiency. So these are the pancreatic exocrine deficiency, and as I already said, this is not only causing fat malabsorption, but it is also causing protein as well as carbohydrate malabsorption as well. Okay. Now after this, we are having defective chylomicron or lipoprotein secretion. So the condition which is in which this is exemplified is A beta lipoproteinemia. It is an autosomal recessive disease characterized by inability to assemble triglyceride rich lipoprotein. So normally the lipids, okay, they are transferred to the apolipoprotein for transport of lipids with the help of MTP, which is a microsomal triglyceride transfer protein, MTP. So in A beta lipoproteinemia, there is a mutation affecting the MTP, which is helping in the transfer of lipids to apolipoprotein. Because of this mutation, okay, what happens that there is an intracellular accumulation of lipid, and the diagnosis is made by a special stain, that is oil red O. Okay. Now plasma over here, if you see, they are devoid of lipoproteins containing apo beta lipoprotein or apolipoprotein beta. Okay, so this is in short about the A beta lipoproteinemia. Okay, that is the defective chylomicron or lipoprotein secretion. Then we are having impaired lipid processing by the bile acids. Okay, because you know that bile acids are very important for fat emulsification, solubilization of the fat, and for further processing and absorption. So whenever there is an inadequate bile synthesis or impaired bile acid secretion, or bile acids are not absorbed from the intestine. Now remember, normally the bile acids, okay, when they enter the intestine, they help in the fat absorption, and once the fat is absorbed, the bile, further they go into the colon, they are reabsorbed into the circulation. So they are not remaining back in the intestine. So normally bile acids are reabsorbed. Okay. So if the bile acids are not reabsorbed in the intestine, so they are not available for fat absorption later on, and whatever bile acids are there in the intestine, they will stimulate colonic water and electrolyte secretion, leading to further malabsorption. Okay. So what are the conditions where you can have issues with bile acid synthesis or impaired bile acid secretion? For example, in liver disease, for example, in conditions of hepatic cirrhosis or systemic amyloidosis, there's a reduced production of bile salts. Or in conditions of cholestasis, because of either intrahepatic or extrahepatic pathology, there is a bile duct obstruction, leading to obstruction in the flow of bile acids. Sometimes there can be a primary bile acid malabsorption syndrome as well. Okay, wherein the bile acids are not absorbed from the intestine, as I've already discussed. So whenever there is a impaired lipid processing because of some problem at the level of bile acid synthesis or transport, or bile acid not being absorbed from the intestine, so fat malabsorption or steatorrhea can result. Okay, so impaired lipid processing by the bile acids. Okay. Then small intestinal bacterial overgrowth, that is SIBO. What is SIBO? It occurs due to excessive bacterial growth in the small intestine. So normally more amount of bacteria is seen in the colon. Usually the amount of bacteria in the small intestine is less. So this is the condition characterized by excessive overgrowth of bacteria in the small intestine. It occurs due to excessive bacterial overgrowth because of a reduced pH in the small intestine, maybe because of excessive acidity of the food which is coming in the intestine, or it can happen because of the slow passage of food and waste products in the small intestine. So they are acting as a breeding ground for growth of bacteria, leading to overgrowth. So two conditions which is predisposition or predisposing is reduced pH at the level of small intestine, or any condition which is slowing the passage of food and waste products in the small intestine, so that there is a stasis causing breeding ground for bacteria. So this condition is characterized by diarrhea, weight loss and malnutrition. So what are the causes of SIBO, that is your small intestinal bacterial overgrowth? First of all, decreased pH of the gastric acid. It can occur secondary to H. pylori induced atrophic gastritis, reduced pH of the gastric acid. Increased use of proton pump inhibitors or gastric bypass surgery. Okay. So gastric bypass surgery. So in all these conditions, there is a decreased pH of the gastric acid because of H. pylori induced atrophic gastritis, increased use of proton pump inhibitors and gastric bypass surgery. In all these conditions, what will happen? There is a reduced pH of the gastric acid. Secondly, small intestinal dysmotility. Example, gastroparesis or intestinal pseudo obstruction, where there is a small intestinal dysmotility, as in conditions of gastroparesis, intestinal pseudo obstruction, etc. Thirdly, structural defects of small intestine or complications of abdominal surgery like small intestinal diverticulosis, abdominal adhesions, etc. Fourthly, associated with certain medical conditions like inflammatory bowel disease or radiation enteritis, or secondary to diabetes mellitus or celiac disease. Okay, so these are the four conditions which are predisposing to which are predisposing to the bacterial overgrowth. So I will just repeat, because whenever the pH will fall means the pH is becoming more basic. So when the pH is going to become more basic, so as a result, more amount of bacteria will survive the stomach and more will enter the small intestine, leading to bacterial overgrowth. Secondly, if the passage of food is slow, it is providing a breeding ground for the bacteria to come. Okay. So any condition where the pH is becoming basic, for example, H. pylori induced atrophic gastritis, increased use of proton pump inhibitors or gastric bypass surgery. Okay. Then small intestinal dysmotility or structural defects or associated with certain medical conditions, all of them can predispose to SIBO or small intestinal bacterial overgrowth. Then the differential diagnosis of SIBO is celiac disease. But you have to remember that SIBO is patchy in nature, whereas celiac disease is a diffuse process. Lastly, you can have lymphatic disorders. For example, Whipple's disease. This is basically an infective condition caused by gram-positive bacteria actinomycetes, that is Tropharima whippleyi. Tropharima whippleyi, it is characterized by a triad of malabsorption, lymphadenopathy and arthritis. So over here you will see microscopically that there is a presence of bacteria laden macrophages. They start to accumulate within the small intestinal lamina propria and the mesenteric lymph nodes, causing lymphatic obstruction leading to impaired lymphatic drainage. This is what happens in Whipple's disease. Okay, macrophages, if you see, they are Pas positive diastase resistant granules representing partially digested bacteria within the lysosomes. Okay, now similar macrophages and similar Pas positive macrophages, Pas positive granules can also be seen in mycobacterial infection. So then how do you differentiate between the mycobacterial infection versus your Whipple's disease? Very easy. Do the AFB testing. AFB will be positive in case of mycobacterial infection, whereas it will be negative in case of Whipple's disease. So what are some of the extraintestinal symptoms of Whipple's disease? It includes arthritis, arthralgia, lymphadenopathy, fever, cardiac pulmonary disease, or even neurological disorders. Okay. Now the second important condition which is which is causing lymphatic disorder is your intestinal lymphangiectasia. More about this we will discuss under the heading of your carbohydrate malabsorption. Okay, we will discuss over there. This is characterized by impaired lymphatic flow impacting fat processing. It is the most common cause of chronic non-infectious infantile diarrhea. So we have completed the fat malabsorption, wherein we have discussed. I will just repeat what all we have discussed very fast. Okay, just a revision, quick revision. So we have seen conditions, the causes of fat malabsorption, including conditions where there is a decreased duodenal pH. Okay, the pH is basically becoming more acidic, for example because of Zollinger-Ellison syndrome. Secondly, because of loss of absorptive area because of diffuse conditions like IBD and celiac disease. Thirdly, pancreatic exocrine deficiency secondary to chronic pancreatitis, carcinoma, resection, cystic fibrosis. Okay, then defect in the lipoprotein secretion, that is A beta lipoproteinemia, as we have already seen. Thirdly, because of impaired lipid processing by bile acids, we have seen the condition liver or cholestasis. Then small intestinal bacterial overgrowth syndrome that we have already seen. This is followed by lymphatic disorders characterized by Whipple's disease and intestinal lymphangiectasia. With this, we have completed the fat malabsorption. Now we will see the carbohydrate malabsorption. So normally remember the starch, lactose, sucrose, they are broken down into monosaccharides starting at the salivary, starting at the level of the mouth only with the release of salivary and pancreatic amylase. All these complex carbohydrates are broken down, and at the level of the brush border epithelium, the disaccharide, trisaccharides, all the disaccharidases, they are all present at the brush border epithelium. So at that level, they are breaking down the carbohydrate further into monosaccharide. Now this monosaccharide form is directly absorbed at the brush border epithelium, and very less amount, okay, may remain inside the intestine, okay, and that undergoes bacterial fermentation, causing fatty acid release, which is absorbed by the colonic cells for energy. So this is what happens normally. But if for any reason, because of a deficiency of the enzyme, or for any reason, if the monosaccharide, they are not absorbed and excessive amount remains in the intestine, so very importantly, they will exert an osmotic force, and they will absorb a lot of water as well as some electrolytes, they will absorb from the intestine, and as a result, what will happen? They will lead to osmotic diarrhea. Not only that, because of the presence of excessive amount of carbohydrate in the intestine, there will be excessive bacterial fermentation leading to acidic stool, flatulence, as well as bloating. Okay, so this is how carbohydrate malabsorption occurs. So the conditions are, as one we have already discussed, the pancreatic exocrine deficiency. So there can be an amylase deficiency, or there can be an inadequate disaccharidase activity, that is either a decreased lactase or a decreased sucrase activity. Out of this, the decreased lactase activity is very common. So lactase deficiency or disaccharidase deficiency is very commonly encountered. It is the most common disaccharidase deficiency encountered. So disaccaridases, including the lactase, are present